The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety. This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Welcome back to the FlightBridgeED Podcast. Back by popular demand, or maybe just because I have something else to say, it's Ashley Bauer again. This podcast focuses on timely material that I think is important to discuss. We could call it a COVID-19 update, but really this is new material and not much to update on at this time. So let's get started. Pediatric cases of COVID-19 have been relatively fewer in comparison to the adult population. Now, in the U.S., statistics are reporting approximately 2% of confirmed cases were in individuals less than 18 years of age. And we compare this to different countries, this tends to run pretty close to what they're reporting as well. So China reports approximately 2.2% among individuals less than 19 years old. Italy, 1.2% in children less than 18 years old. And in Spain, about 0.8% of confirmed cases of COVID-19 were in individuals less than 18 years of age. However, over the past couple of weeks, there seems to be this apparent rise in the number of children presenting with a multi-system inflammatory state to the point that some are requiring intensive care with this. So due to this increasing awareness, the number of cases tends to be increasing worldwide as well. This overall problem is being termed multi-system inflammatory syndrome in children, or you'll see it abbreviated as MIS-C. So we're seeing more of these syndromes and more children are testing positive, but we have to stop and ask ourselves, now, why exactly is that? So we could say that perhaps the increase in both is really a result of selection bias. Initially, we were told that children rarely get COVID, and if they did, they really were rarely ill from it. So this may have likely influenced parents to not present initially for testing, as well as influenced clinicians to just not test kids, right? So we were told that, kids really don't get sick. So parents probably think, oh, this is just a virus. They'll get better soon. And as clinicians, we were probably, within the mindset that these kids rarely get very ill. So maybe it is COVID, maybe it's just a virus, but they'll be fine. Send them home. No reason to test, no reason to work them up. So as a result of this, it's really not surprising that there was such a small portion of kids that were positive. And also because we so-called knew that kids didn't get sick from COVID, we were not likely to consider COVID when we started being presented with these sick kids. So back in the day, and I say back in the day very loosely, before this syndrome was even described, nobody really considered that such a thing could have potentially been a result of COVID. So now that it has been associated, now that this association is made, so far more clinicians are now considering it and now all of a sudden, quote unquote, seeing it. So our medical director, Dr. Jeff Jarvis, shared this phrase with me, which I thought was pretty profound. And he said, the eyes don't see what the brain doesn't consider, meaning that you will not make the diagnosis of a disease that you didn't initially include in your differential, which I think was pretty fitting, especially when we started seeing these cases of COVID-19 in these sick kids, and before that association was even made. So while we're discussing COVID-19 among pediatric patients, we might as well step back and just hit on the clinical presentation of this age group. Most of these cases do appear to be mild in nature with just symptoms of an upper respiratory infection such as cough, runny nose, sore throat, fever. The initial workup can be very similar to the adult population. It is true, as it is with most adults, that few hospitalizations do occur with kids. And those hospitalized to this point were usually less than a year old or those with underlying health conditions. So this syndrome is also being compared to Kawasaki disease, although there are some differences between the two. There's one source that was noted as describing this syndrome with overlapping features of toxic shock syndrome and atypical Kawasaki disease, which I think is, pretty interesting when you look at the overall presentation of these kids. Lab tests have also been pretty consistent with severe COVID-19 in these kids, including those elevated inflammatory markers like their CRP, ferritin, D-dimer. Kind of very similar to what we're seeing in the adult population. And it's not that this syndrome is all of a sudden new and unknown. It's formally referred to as the Pediatric Inflammatory Multisystem Syndrome, or PIMS for abbreviation. So it's been around, but the incidence has dramatically increased in comparison to the number of cases that were previously seen. So in this multisystem inflammatory syndrome in children, it does appear to be a post-infectious disease with symptom onset usually beginning about 2 to 4 weeks after a child has been infected with the SARS-CoV-2 or that COVID-19 illness. There is a study out there that is suggesting a possible connection in genetically predisposed children. However, I will warn that there's a significant lack of well-developed studies, clear expectations at this time. So that's really not been solidified and 100% proven, really. As with most other situations that's associated with COVID-19, the healthcare industry in general is just trying to do their best with the information that they currently have, which seems to be pretty limited in most cases. So now that we're to this point, let's take a minute and let's back up a little here. And let's do a brief overview of what we call classic Kawasaki disease. So when we're looking at the classic Kawasaki disease, it's an acute febrile illness, usually with an unknown etiology behind it. You're primarily going to see this in kids younger than 5 years of age. It does cause inflammation or swelling within the walls of medium-sized arteries. And the major concern with Kawasaki disease is the potential complication of coronary artery abnormalities. And that's usually the biggest concern whenever we're discussing Kawasaki disease, are that complication. Diagnosis usually is clinical in these kids, and usually that includes a prolonged fever, generally greater than 5 days. You may see skin changes in the extremities, which primarily includes edema, erythema, maybe the desquamation, which is the peeling of the skin, but primarily that's going to be found in the hands and feet. You may see rash in these kids, conjunctivitis, cheilitis, which is that red, chapped-looking lips, glossitis, which is that red, swollen tongue that looks like a strawberry, pharyngitis or throat pain, and cervical lymphadenopathy, which tends to be unilateral. It could be bilateral, but primarily you see one side affected over another, or seems to be larger than the other. Management of classic Kawasaki is mostly IV immune globulin and corticosteroids in nature, and then supportive therapy as well. Okay, so now that we've discussed this classic presentation and management of Kawasaki disease, let's transition back to what we're seeing in this newer syndrome, so this multisystem inflammatory syndrome in children. So in this inflammatory state, it does seem to occur from a surge of cytokines which rearranges body functions, similar to what we've also seen in the adult population. Most importantly, it causes leaking from vessels. And if you've heard our sepsis education or listened to that podcast, it's very, very similar to what we talk about in that within that education. So this leads to hypotension, pulmonary edema, these shock-type states that we see in these kids. However, there also seems to be this mix of an atypical Kawasaki-type presentation or component seen with it, similar to what we just discussed before. One pretty constant symptom in these patients with this multisystem inflammatory syndrome in children is persistent fever, usually greater than 4 days. Another prominent symptom that we're seeing is diarrhea, some abdominal pain, followed by very symptoms including a rash, vomiting, conjunctivitis, maybe myalgia, odonophagia, maybe headache. It's important to remember here, though, that these children may have been asymptomatically infected, and they may not have initially even known they were infected before presenting with this multisystem type involvement. Overall, in these kids, management does tend to be supportive. Most children are improving fairly quickly, but there are some that may require cardiac or respiratory support. Other treatment modalities that have been kind of tested with have included the use of IV immunoglobulins, possible antibiotics, possible corticosteroids. Again, that's just going to depend on your patient presentation, and how sick that kid actually is. So overall, this syndrome, it does still seem to be pretty rare, and most kids will be spared from overall morbidity and mortality that's associated with COVID-19. To reiterate, there is a significant limitation in information thus far, and there's been very little published and supported data out there. So this is likely to change considerably in the near future as more data becomes available, as more information is available to the healthcare industry. However, as healthcare providers, I think this is something you need to be aware of and prepared for should you encounter it. So in summary, as always, please feel free to email me. It's ashley.bauer@flightbridgeed.com should you have any questions or concerns. And always, stay safe, stay healthy. We will talk to you soon.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.